Good afternoon to all our attendees. My name is Camille Delva, and welcome to the Scarring Alopecia Summit. We are truly grateful for the involvement and dedication of our amazing presenters today. Thank you for sharing your time and expertise with all of us. The webinar we've meticulously prepared for you is crafted to delve into significant areas that matter most to our community. We'll be exploring research, current and emerging treatments, mental health, medically verified information, expert-led Q&A sessions, and practical advice for daily living. Our aim is to provide you with a comprehensive understanding that empowers and uplifts. With over 450 patients registered today and an extensive program for over 3.5 hours of information, we anticipate an information-packed session that promises to be both substantial and rewarding. Recognizing that knowledge is empowering and being a part of a community is comforting, we look forward to a great session ahead. Now, before we dive into the content planned for today, let's take a moment to break the ice and get to know each other. Let's take a poll. How long have you been living with scarring alopecia? All right, I see some of you have been dealing with this for quite some time. Now, how about another question? Out of all these four choices, which is the most important to you in your scarring alopecia journey?
I'm not able to see any questions. Oh.
All right. Thank you everyone for your participation. We plan to address these aspects in the webinar. Now, let me introduce our wonderful Master of Ceremonies for today, who will guide us through this enriching journey, Dr. Divya Sharma.
Hello, everyone. Thanks for joining us today. And thanks, Camille. I'm Dr. Divya Sharma. I'm a dermatologist and hair specialist currently in the San Francisco Bay Area, and we'll be moving to Massachusetts next year to join Leahy Health's Hair Loss Center of Excellence. Me and all the other speakers are excited to be here with you today to talk more about scarring alopecia. I'll be helping today as the MC and will also be joining in one of the breakout rooms later today. I have to say, this virtual webinar will be so helpful to many of you, and I can't wait to get started with our content. First, I'd like to just address some general housekeeping. To keep the background noise at a minimum, we're asking everyone to just keep your Zoom muted. And as a reminder, this Zoom is being recorded, so if you prefer not to have your face and/or your name visible, you can check your Zoom controls and edit those accordingly. We also know that many of you have submitted questions when you registered, and these pre-webinar questions have already been forwarded to our speakers, who will do their best to address those in their presentations. And also keep in mind, you will have an opportunity to ask live questions in the breakout rooms later this afternoon. So we have an exciting lineup of high-quality speakers and a lot planned for today, so we'll get right to it. Our first session will be a general focus on what to know about scarring alopecia, covering research updates and emerging therapies. Dr. Rhonda Farah will be our presenter. She is an assistant professor in the Department of Dermatology at the University of Minnesota and co-chair of SAF's Medical and Scientific Advisory Board. She is an expert in hair loss and laser-based medicine. You may have also seen her on TikTok, as she is very active on social media with dermatology-related education and healthy skin practices. Dr. Farah is an active member of the American Hair Research Society, and she's also served on the board of directors for the Women's Dermatology Society. So over to you, Dr. Farah.
Hi, everyone. I'm Dr. Farah. I'm going to be presenting with Kim. She is our current hair research fellow at the University of Minnesota. Can you hear me okay? Kim, can you tell me if you can hear me okay?
I can hear you.
Okay, perfect. And then we also want to thank our second year medical student, Muhab, for helping us with this presentation. So we're going to begin just giving you an overview on scarring alopecia management. So I am currently an American Academy of Dermatology social media correspondent. So I'll talk a little bit about social media just because I'm interested in that. I do want to point out, and I'm sure many of you know this, scarring alopecias have very early treatment options. So most of what we're talking about is not FDA approved, and there's very limited data. A lot of it is clinical experience. And we really encourage our patients to stick with a board certified dermatologist when they're getting their hair care. So our outline, we're going to talk about the definition of scarring alopecia, go through the pathology, which means what we see underneath the microscope, the diagnosis of scarring alopecia, the different types, and then the updates we found in the literature for this presentation. So the definition, let's go ahead and talk about how scarring alopecia, you might hear your doctor use the term cicatricial alopecia. And alopecia means hair loss. Okay, and cicatricial means scarring. So when we put those two words together, we get cicatricial alopecia. Whenever the hair follicle is irreversibly destroyed with a scar, because there's fibrous tissue under the skin, we call it a scarring alopecia. So here are the different types of scarring alopecia. We're going to start with we call it CCCA, then lichen planopilaris, and I won't read the rest of these, but we're going to go through these 6 groups and a few little subtypes of scarring alopecia that fit under this umbrella term. When we do a biopsy, we send it, that piece of skin, to the lab, okay? Typically, your dermatologist will take 2 skin biopsies, each just a little smaller than a pencil eraser. And then when we send it to the lab, that dermatopathologist, that's a dermatology, a person who examines slides, many of which have had tons of dermatology exposure. And we see inflammation near the hair follicle and fibers. And that pathologist will look under the slide, look where that inflammation is, that's the black dots. Look at where the stem cell region is and the oil glands, and putting all those pieces together and the way they look, try to give us a diagnosis. So when we're making that diagnosis, the dermatologist will typically take 2 pieces of skin. In general, and this isn't for everybody has a different practice, but many dermatologists will choose to do 2 4-millimeter punch biopsies. The word punch is just not the funnest word, but it's actually fairly simple. We numb up the skin just with, it feels like a little bee sting and it wheels up. And then we take this little device. It's like a cookie cutter. It's just a little smaller than a pencil eraser. And then we push it straight through the skin and pull up. And that piece of skin just comes popping out. You really need a dermatologist to do this procedure. If it's not done in the correct plane, or if the hair follicles are all transected, it can make it so that underneath the microscope, you don't get a very good diagnosis. And anytime we do a punch biopsy, I tell my patients it's like sampling a jelly donut. Sometimes you get really lucky and you get the jelly, and sometimes you get the side of the donut. So sometimes your dermatologist has to do it a couple times. So here's an example of a punch biopsy. Here you can see it's been numbed. So you see a couple little red dots where there was blood there because they numbed it, typically with lidocaine, similar to the dentist. Then they take this cookie cutter device and then we sort of twist it down all the way generally to that hub, that green area. And then that piece of skin pops out. We make sure we have intact hair follicles and we send it into the lab. So let's talk a little bit about what's been emerging and then each of the different types of hair loss disorders.
All right, so the first
So
scarring,
diagnosis number one for Kim.
so the first one we're going to talk about is discoid lupus. This is a scarring skin or hair disease. Sometimes this does affect the entire body, and then in that case, it would be termed systemic lupus, most often referred to just as lupus in the media. So this presents with round sores, most commonly on the face or scalp, such as the picture to the right. The lesions tend to be in photodistributed areas. This just means where the sun shines most on the skin, and this leads to scars. Most commonly, discoid lupus is treated with sunscreen in conjunction with topical steroids or a topical calcineurin inhibitor. Providers may also add some steroid injections too.
So when we're talking about discoid lupus, many times we see that on the face and the ears. Since we're talking about hair loss today, let's focus on discoid lupus of the scalp. Sorry, that's my kid. There'll be monsters in the show coming. We'll keep going. So our current therapies, when we're talking about oral medications, are going to be hydroxychloroquine or other immunosuppressants. There's all these other things that are up and coming, and we put them up on the slide, but they're not first-line treatment. Typically, first-line treatments right now are topical anti-inflammatories, topical steroids. We might off-label use topical minoxidil, and we might inject, and then we'll typically work with a rheumatologist if there's other areas of the body involved, like the kidneys, and oftentimes go to that hydroxychloroquine. So that's sort of where we're at with discoid lupus. Yeah.
So the second one we'll talk about is kind of a grouping of lichen-planopilaris and frontal fibrosing alopecia. The frontal fibrosing alopecia is currently considered a variant of lichen-planopilaris, and the eyebrows are often involved with this condition, presenting with thinning or loss in those regions. And then some common clinical characteristics include pain, itch, perifollicular scale, so scale hugging the hair follicle, and erythema or redness around the hair follicle. And these are actually included criteria in the severity score of the disease. And on trichoscopy, which is just a fancy dermatologist magnifying glass, sometimes we see these white dots, which often help us with diagnosis. And traditionally, steroids are often used as first-line treatment, either topical or injections, and then topical calcineurin inhibitors can also be used.
That was great, Kim. So I see a ton of frontal fibrosing alopecia. I really think that we have some sort of epidemic or increasing rate of frontal fibrosing alopecia. And again, many people believe that that's a variant of lichen-planopilaris. And we still have a lot of science to work out with this. You might see your dermatologist consider using finasteride or dutasteride, hydroxychloroquine, again, which is that anti-malarial medication, oral antibiotics. And the reason for oral antibiotics is we really want to bring in or reduce the inflammation. So we're not trying to cure any sort of infection, but reduce inflammation. And some people will use isotretinoin. I don't typically use that. Now, emerging in the literature, you might see dermatologists trying to use platelet-rich plasma, which is where we take your blood and we take the platelet-rich portion and inject it. We might consider oral minoxidil. I have several patients on oral minoxidil. I've seen some improvement with that. Again, this is very, very early data. In medicine, we are very focused on evidence, okay? So we tell our patients there's very little data for this, but they want to grow hair, and if it's low risk, and they have few medical issues that make the treatments high risk, we'll move forward with those treatments. And you might see your dermatologist reach for other things that suppress the immune system, methotrexate, mycophenolate mofetil, and these other medications, again, with a low level of evidence.
All right, so the next one is centrifugal cicatricial alopecia, other known as CCA for short. So this, regarding demographics, it's often seen in Black women. It can also run in families. This presents as patches of permanent hair loss on the scalp, and it spreads in the centrifugal pattern, which really means scarring tends to continue away from a center point. And then a common intervention used in clinic is local steroid therapy, and oral tetracyclines, which are antibiotics, are often used too.
Yeah, I love that summary. So yes, topical steroids to reduce inflammation. Tetracycline oral antibiotics often are used to reduce inflammation. Yeah, somebody's asking about tetracyclines and chronic antibiotic use. Of course, we're always thinking about that, but we also have patients that are losing their hair permanently. So the dermatologist and a physician, an evidence-based physician in the United States, is trained to weigh risk and benefit. What is the risk of that patient taking the drug versus the benefit? If the patient really wants to grow hair and it's generally low risk for them, we'll do it. Antibiotic resistance is an issue. It is a risk. We don't see that problem a lot with our hair loss patients, but it is something to talk about. And I always tell my patients, every single treatment I give you has a risk. And when you drive to my clinic today, you took a risk. You drove a car. So we just really have to balance that patient's medical problems, what they're willing to do for their hair loss. Some patients don't even want to treat their hair loss, and we want to respect that too. It's really a conversation between the physician and the doctor. Topical calcineurin inhibitors are also off-label use. Those are anti-inflammatory medications that are not steroids, so they won't thin the skin, but can be a little bit irritating. And again, suppressing the immune system. This sort of disease is one where we really need to optimize our scalp health. We don't want to see a lot of scaling. We don't want to see a ton of extra product on the scalp. We want to shampoo. In our very curly hair types, we want to think about shampooing once a week. I like to aim for once a week or every 10 days or at least every 2 weeks if the hair is very, very curly and dry and breaks easily. Minimizing heat, avoiding tight styles, limiting to relaxers to when they're absolutely necessary, because we're not sure, but we're concerned that that might contribute to this disease again. So we keep this in mind. It's shared decision making. Some patients have to use heat on their hair with this disease. We understand as dermatologists. We're going to work around it as much as we can. Emerging topical minoxidil, many patients can use, and it can be helpful. Not FDA approved, but can be helpful, pretty low risk. Oral minoxidil, I've used oral minoxidil in this disease and seen great improvement. Again, this is anecdotal. We need more evidence for this, but I think there is a window for this to emerge as a treatment option. Light therapy, so those combs and hats. Platelet-rich plasma, again, where we take your blood, we spin it down, we inject the platelet-rich portion. We need more evidence and more studies for that, but you might see your dermatologist reaching for these lower risk options if you really want to grow hair and they're low risk for you. And then there's a recent case report, just a case report. So that means just one patient who improved with a little, I think it was one patient, it was very limited study where Botox was helpful. Again, very low level of evidence. So that doesn't mean it's for everyone. And it's for surely not going to be up there with our topical steroids and our tetracyclines and improving our scalp health, but all things a dermatologist might talk to you about.
All right, folliculitis decalvans. So this is a chronic neutrophilic inflammation of the hair follicle. Neutrophils are just white blood cells in the body that often cause pus. So that's what that means. And this also, of course, causes scarring. This is commonly seen in adult males, and you can see this involving the crown or the top of the head or the back areas of the scalp. This classically presents as an expanding patch of alopecia with perifollicular erythema or redness, so redness around each of the hair follicles, which you can see depicted to the right there. You can also see some crusting and some pus-filled bumps. For treatments, oral antibiotics and isotretinoin are commonly used.
So again, the anti-inflammation, we might use tetracycline antibiotics, clindamycin, rifampin. This is a very inflammatory pustular disease. So it can require more antibiotics than typically than the other diseases. We might look at medications that slightly alter the immune system, such as dapsone. That's a medicine dermatologists use to reduce inflammation and special inflammatory cells called neutrophils. And that does require some lab monitoring. Humira, which is one of those psoriasis medications, has a little bit of evidence, and apremilast, another psoriasis medication. I think we're going to see a lot of this start to emerge. Again, the Botox or botulinum toxin, again, very limited data a dermatologist might reach for, and then light treatment. So I'm sort of taking you guys through things a dermatologist might reach for, newer evolving treatments, just so you can see where this field is going. But I see some comments about, what about this medication? What about this? there are many things reported in the literature your dermatologist might reach for, and those could be helpful for you. And if they're coming from a board certified dermatologist who's managing you, they're probably great. It's all going to be about just trying it, because there's such small groups of patients with this disease and so little research that it's really working closely with that dermatologist where you can optimize that treatment plan. And I saw another question about insurance coverage. Right now, Medicare is very behind defining these hair loss diseases with their coding, and very far behind with platelet-rich plasma coding and light-based treatment coding, not just for hair loss disease, but many skin diseases. So that can be a huge barrier for our patients. And in addition to being stressful to you guys, is breaks our hearts. And so we're there to help you guys advocate for that. Let's keep going, Kim.
Right, the next hair loss disorder is called dissecting cellulitis of the scalp. This is a chronic inflammatory disorder of the scalp characterized by pus-like lesions and nodules with patchy hair loss, which you can see to the right. This is most commonly seen in middle-aged men of Afro-Caribbean descent, and this is also seen on that vertex or crown area on top and also the back regions of the scalp. A lot of these patients also have hidradenitis suppurativa. Many of you guys may have heard of this disorder, but essentially you also see pus-like lesions and nodules, except in different regions of the body. So you often see that in places like the armpit, for example. For this disorder, treatment is limited, but the most common ones used so far are oral antibiotics such as clindamycin, rifampin, isotretinoin, and again, steroids.
You'll see a lot more isotretinoin use in that disease. A lot of these patients also have hidradenitis, and so, sorry, I saw a question come up there, so I was trying to read it. I'll come back to the question. So a lot of the patients with dissecting cellulitis also can have hidradenitis. And we see a lot of drainage with this disease, so you might see us do more procedures, try anti-inflammatories like we've talked about. Kim and the medical student actually dug into the literature. There's some evolution in this disease into some people in very small studies considering lasers, but that's very early. And again, using those psoriasis drugs, which are now FDA approved for hidradenitis, which many of these patients also have. So I think you're going to see dermatologists reaching towards that group of medications.
Okay,
You
and
can
then
go ahead.
acne keloidalis nuchae. So this is a persistent inflammation of hair follicles affecting the base of the neck, otherwise known as the nape of the neck. And in the picture to the right, you'll see keloid-like scars, which are very common, and also pus-like bumps. This is most common in Afro-Caribbean males, especially with curly hair. And most commonly in clinics, you'll see this treated with topical antimicrobial cleansers, such as gentle foaming benzoyl peroxide. But the research is pretty limited so far with what is recommended for this disorder.
Yeah, we can also use topical steroids and intralesional steroids, which Kim, I think we may have just deleted accidentally off that slide this morning, but that's okay. So topical steroids, intralesional steroids, and then we found some emerging treatments. Sometimes if it's really quiet, your dermatologist might consider excising it, which means removing it surgically. And then there's some light treatments that have been reported. Again, things we're reaching for, very unique to the patient, their medical problems, and the dermatologist doing a localized test of that area to see if it's helpful. So Kim, if you want to keep going forward, we have probably 1 minute left. So our conclusion, as you know, there's the dermatologists are really passionate about hair loss disease and specifically scarring alopecia. We understand that it is a very broad group of diseases and that there's always new emerging therapies, but that relationship with a dermatologist and testing these treatments out for each of you and their risk and benefit is so important. And the next slide, and a lot of the questions we'll talk about that you guys proposed, hopefully in our group sections. You can find me, I'm Dr. Farah, on Instagram, TikTok, and Twitter. I really encourage you to follow board certified dermatologists. There's a lot of hair loss medical advice that can actually be harmful to the scalp, cause worsening, plugging, inflammation, and drive disease. Kim, thank you, thank you, thank you. Mohab, thank you, thank you, thank you. They actually wrote this talk. I edited it. Kim is amazing. Thank you to all the patients that took the time to listen to this. We're so happy to collaborate with you. And thank you to my toddlers behind me for not interrupting me the entire time. Thank you, everyone.
Thank you, Dr. Farah, Kim, and to Mohab as well for this incredibly informative session.